Hello and welcome to today's presentation. Thank you for joining us. We're so excited to spend the next hour with you exploring how hospitals can advance infection prevention with data-driven strategies and proven best practices, powered by electronic hand hygiene monitoring technology. My name is Katie Nolte. I'm the Marketing Communications Manager at CenTrak, and I'll be serving as today's moderator. We'll begin with a few housekeeping items. The webinar is expected to last approximately 60 minutes with a Q&A session at the end. As a reminder, you are in listen-only mode. If you have any questions during the webinar, please type them into the Q&A box and they'll be answered during that portion of the webinar. This call is being recorded and the recording and the slide deck will be shared with you tomorrow. We're excited to be joined by two experts at the intersection of infection prevention, clinical operations, and healthcare technology. Dr. John Steele, PhD, CIC, and Director of Service and Customer Analytics at CenTrak, is a seasoned healthcare analytics and infection prevention leader with a deep expertise in leveraging RTLS technology to drive measurable improvements in safety, efficiency, and clinical outcomes. At CenTrak, he guides data-driven strategies across use cases, including hand hygiene, environmental monitoring, staff duress, and patient flow. Prior to joining CenTrak, John served as System Director of Infection Prevention at Atrium Health Wake Forest Baptist, where he oversaw infection prevention programs across 5 hospitals and more than 400 outpatient clinics. His extensive experience in implementing, validating, and optimizing clinical software platforms gives him a unique perspective on bridging data, workflows, and real-world hospital challenges. And Danielle Updegraft, MBA, BSN, RN, clinical nurse educator at CenTrak, brings over 2 decades of nursing experience and a passion for improving care delivery through technology. Before joining CenTrak, she served as Director of Clinical Projects at HCA's Hospital of the Future, where she led deployment and training for cutting-edge solutions, including electronic hand hygiene monitoring, asset tracking, and nurse call integration. A Leapfrog certified coach, Danielle combines clinical insight with operational expertise to help healthcare systems and teams successfully adopt innovation and elevate patient care. Together, John and Danielle bring both clinical and analytical perspectives to advancing infection prevention through digital innovation. Healthcare organizations are under constant pressure to improve patient safety, meet regulatory standards, and do more with less. Yet traditional hand hygiene observation methods often fall short, offering limited data, inconsistent results, and unsustainable labor demands. This session will explore how electronic hand hygiene monitoring delivers continuous, unbiased insights that drive accountability and compliance across teams, fostering a culture of safety, reduce healthcare-associated infections and associated costs by providing actionable data-driven guidance, support policy and regulatory compliance, including accreditation standards and internal policies, lay the foundation for broader safety and operational initiatives, leveraging RTLS technology to extend beyond hand hygiene into areas such as staff duress, environmental monitoring, and workflow optimization. You'll also hear real-world results and practical strategies to help your organization strengthen infection prevention and enhance patient outcomes. At CenTrak, our mission is to make healthcare safer and more efficient. While our RTLS technology supports many use cases, today we'll focus on electronic hand hygiene compliance, part of our broader infection control solutions. The same BLE multi-mode badge, as you can see here, that enables hand hygiene monitoring also supports staff duress, nurse call automation, and workflow optimization, allowing multiple departments to share technology, split costs, and maximize efficiencies. By working together across teams, hospitals can achieve better outcomes for both patients and staff, all with a single versatile badge. And as you can see here, CenTrak has extensive experience across many facilities in multiple countries. We've been doing this for a long time, and our team of clinical and technical experts ensure successful system adoption and deliver measurable results. This experience is what makes us trusted leaders in hand hygiene compliance and RTLS. And with that, I will turn it over to John to get us started.
Thank you, Katie. Welcome, everyone. So I'm going to be highlighting some of the background on hand hygiene compliance, the importance of it. Obviously, if you're joining this webinar, you're already aware of the importance of it. But obviously, the we care about hand hygiene compliance because, as then that first bullet, we avoid becoming a carrier and we stop the spread of disease, which leads to the second two bullets. You could decrease the number of healthcare associated infections, which is good for the safety of the patient, as well as minimize work environment as a source of staff illness. So obviously you want to keep your staff healthy and working. And so it goes a long way with that as well. And then sort of the bonus is you ensure regulatory compliance across all those agencies. Just a reminder, the WHO's 5 moments for hand hygiene are kind of highlighted on the diagram there. Obviously, it's before touching the patient. I always like to add in and the patient's surroundings. So that's why most of the time we always recommend the hand hygiene upon entering the room, because you also don't want to lead anything that you touch to become a fomite for transmitting the germs elsewhere. Before any clean or aseptic procedure, after body or fluid exposure risk, after touching the patient, and then after touching the patient's surroundings, which obviously gets covered whenever you do hand hygiene upon leaving the patient's room. Next slide. So we see the importance, and then we start to understand, okay, why are staff not 100% compliant? And it's never because they are just choosing not to do it. There's a lot of challenges that come into this. There's time constraints and competing priorities. So there's busy schedules. They're trying to kind of decipher between the importance of patient care and those hand hygiene actions. Is all of the supply and access to the locations of the devices all accessible and convenient? Is there proper compliance and monitoring that way? If they aren't doing it, are they being educated about it? And just kind of lack of awareness sometimes whenever they go through and they weren't trained either by their peers or by formal training. They just aren't quite understanding how important it is to be doing proper hand hygiene at all times. So there's kind of highlighting some of the challenges, but again, they're not trying to do it out of just being mean about it, I guess. Next slide. So we see the importance, we see the challenges, and obviously, whenever you have those types of components, it's going to lead both regulatory and safety organizations to provide some guidance on that. For example, we have the hand hygiene observations that are going to range from 15 to 200 monthly. That is something that Leapfrog is recommending. Have the quote there, as well as most hospitals that are Joint Commission. They're going to be they're going to have a complete understanding of what that Joint Commission requirement is regarding needing to be monitoring in some manner the hand hygiene compliance, as well as providing optimal feedback and education as needed. So again, just highlighting the importance. So just to dive a little bit deeper, why do the regulatory orgs and everyone else care about the compliance? This is going to highlight a couple of the studies that are referenced by the WHO and their recommendations. We'll expand on these a little bit here shortly, but they just to highlight a few of them. In one study, is hand hygiene compliance was increasing from poor or less than 60% to excellent or greater than 90% is how they were defining it. For every 10% improvement, there was a 24% decrease in the risk of HAIs. There's been another study looking at showing that significant increases in hand hygiene compliance from low, which they defined as 30 to 40%, to high compliance, which they defined as 65 to 82%, results in a 51% decrease in MRSA transmission. And then the research paper from the National Hand Hygiene Initiative in Australia showed that improvement of hand hygiene compliance from approximately 40 to approximately 67% decreased respiratory outbreaks. And then as you get hand hygiene compliance levels approaching 70%, it showed the greatest MRSA and E. coli incidence rate reduction. And then the curve there is just kind of a representative showing that as we have the HAI risk goes down, as the hand hygiene compliance goes up, which is the same picture that all of these studies are pointing to. So then the next question becomes, how do we monitor for hand hygiene compliance? I have 4 of the key ways listed here. I'm going to start actually at the bottom. The 2 at the top with the asterisks are the ones we'll touch upon, but 2 of the ways are through product usage. So this simply means that the amount of soap or sanitizer is being weighed and based on numerous assumptions, based on the patient population, among other factors. They'll determine how many hand hygiene moments occurred, and then they'll try to decipher how many opportunities there were with those assumptions. The electronic method, there's two of them listed here. The first is the video monitoring. That's pretty straightforward. It simply is. Videos are used to capture the processes being done in areas that are monitored by the video, and then either someone can do it in real time, or they could come back after the fact, or in the today's day and age with AI and everything else, there's going to be ways that they could probably utilize the AI technology to start to monitor that as well. So then as we shift up, we have what was always kind of considered the gold standard, the direct observation or secret shopper. This is simply where hospital staff, this could be frontline clinical staff, it could be infection prevention, they're all directly watching and documenting the staff compliance. The person doing the monitoring may be known, which would be just sort of the direct observation, or they could attempt to be unknown, which would be, we always call the secret shopper. The ones that are unknown usually tend to be known pretty quickly. So that tends to be one of the challenges. And then the other option here is is another electronic method example, which is the staff and dispenser sensors. As Katie has showed, the staff wears a badge. There's sensors in the sanitizer and soap dispensers. And then whenever there's an interaction there, it'll record as staff are leaving and entering the room. And Daniel will expand a lot more on this shortly and dive a little deeper into that. Next slide. So as I mentioned, direct observations were always the gold standard, are always the gold standard. I think that picture's starting to change some now. It has some key challenges that need to be overcome. I'm highlighting a couple of them in the next few slides here. The first is you only get a limited observation, so you don't get this complete compliance picture of how staff is performing. There's been a number of studies that are estimating that direct observation only captures somewhere between 1.4% or maybe 4.5% of all hand hygiene opportunities. There's been additional studies that actually attempt to estimate how many total hand hygiene opportunities are there available. That's what the table on the right is showing. You'll see there's a pretty big spread there. Minimum they recorded was 30, maximum was 179, with the average and median being 82 and 72. This variation tends to be due to the type of unit it is, whether it's an ICU, step down, a standard unit, as well as what is the average daily census. So that's why you kind of get that big range across those studies that we're trying to estimate what the hand hygiene opportunity is. The table on the bottom is just kind of an example of showing, okay, if we take the median hand hygiene opportunity value and we say the average daily census is somewhere between 5 or 30, and you multiply that across there, I like to show this as the example. You can see that on any given day, there should be 364 to 2,000 hand hygiene opportunities. If we assume that there's other studies that are only shown maybe on average 2% are being captured, then those numbers on the right are showing kind of what you would be expecting the folks doing the direct observations to be observing. So you can see it's a pretty stark contrast and drop in that. Next slide. So the other challenge that the direct observations have is what's known as the Hawthorne effect. This always skews the compliance picture better. And if you're not familiar with the Hawthorne effect, basically it is the phenomenon where individuals will change their behavior because they know they're being watched. So this, I think the best real world example of this is if you're cruising down the highway and you all of a sudden you see that police officer, you tend to make sure you're going the speed limit because you know you're being watched. If you weren't being watched, then who knows if you were actually doing the speed limit or not. So the same type of aspect occurs whenever they're being watched doing hand hygiene or any other clinical behavior. So if they know they're being watched, they're going to make sure they're attentive and doing the proper hand hygiene when they need to be doing it. There's actually a decent number of studies now that have been trying to explore this association. This is a summary of 13 studies that I've reviewed, looking the effect that the Hawthorne effect has on hand hygiene. And all these references are at the end. So if you want to explore any of them yourself, you're more than welcome. But basically, you'll see that the relative change they all reported across the studies range. The average was about 54% or 56%. The percentile point change, or the actual change in the percentages, the average was about 36%, median 34%, and then there was a minimum between 11 and 66%. So what that means is that whenever the staff was being watched, that in general, they were somewhere between 11 and 66% performing proper hand hygiene than they would be if they weren't being watched. Again, trying to show an example of what this looks like. If you look at the blue line, blue bar graph, that's an example of, okay, what would the direct observation be reported? So going from 40% up to 90%, the gold bar is representing, okay, if we actually adjust that down by, we're going to use 35% for this example, the reality of the hand hygiene opportunities that are there is probably somewhere in the 5 to 55% range. And this is something that I actually witnessed myself when we were doing some pilot studies on the hand hygiene deployment. We had our hand hygiene observers that were reporting out somewhere between 85 and 90%, which I think was accurate what they were seeing. When we did this pilot of the automated hand hygiene monitoring, it came back to be 62%. So we were right in line with what that 30 or so percent improvement was whenever they were being watched. The other thing to note too is the Hawthorne effect related to this direct observation is a challenge that's in addition to any inner observer variation. So different folks that are doing the monitoring of the hand hygiene can actually interpret things differently. It seems like a pretty straightforward process. However, there's a lot of subtleties to it that folks can interpret differently. And so then you get some variation in what the actual compliance rate is. Next slide. So what is the electronic hand hygiene system? And like I said, this is going to, Danielle's going to dive more into this, but it's really just trying to collect information really in an unbiased process to identify both the opportunities that the staff have, as well as what is the actual compliance. It's a tool really that we state it as a tool because it's not to necessarily replace everything, but it's meant to be a way to capture it and then provide the appropriate education and interventions as necessary. But it's a tool that overcomes some of those challenges with the direct observations, such as the limited observations and Hawthorne effect. And then actually there's a statement from Leapfrog's 2025 hospital survey fact sheet that highlights the importance that they feel that the electronic hand hygiene systems have right there regarding that they want purchasers to make sure they send the message that it really should be a consideration about evaluating some of the automated hand hygiene because it can help overcome some of those factors. Next slide. So next, we'll touch upon a few things about the investment that you need to do and the results that will come out and what kind of value you could expect to potentially obtain out of the automated hand hygiene monitoring and improvement of hand hygiene compliance rates. Next slide. So as I think most everyone's aware, the healthcare associated infections are costly. This data changes slightly from year to year, but largely remains unchanged. Hospital patients have a 1 in 31 chance of acquiring an HAI. There's 98,000, almost 100,000 deaths per year due to HAIs, and they're very costly. They cost is something that should be preventable, and their estimates are somewhere between $34 and $74 billion that are being spent on the treating and monitoring the HAI rates. Go to the next slide. So one of the first things that you can start to appreciate is what the soft dollar savings could be for the hand hygiene direct observations. Obviously, you have to have FTEs that are performing this. They may not be a full-time FTE that's doing the hand hygiene observations, but somebody's going to be doing it. For the basis of this example, we were using kind of an average hourly rate of what a registered nurse, a nurse manager, depending on the platform that is being done or the process is being done in each hospital, an infection preventionist or CNA or CMA, as well as a hand hygiene monitor. So we kind of averaged those hourly rates together to give us that. And then we said, okay, if we had a 400-bed hospital with 20 units and we wanted them to gather 200 observations, that would be about 4,000 hand hygiene audits per month. So when you calculate all that out, it equates to about 511 hours, which is about a month that's being spent in theory on doing this, which is the equivalent of about $17,000, almost 18,000. And when you multiply that out, it's a fairly significant amount. And I know that this is something too that some groups have actually used to take to their financial leadership to understand, okay, can we utilize this to try to help offset some of these costs and allow especially clinical staff to go back and be working at their license level as opposed to performing hand hygiene observations. Next slide. So the other part of this is the ultimate goal is obviously to reduce the HAIs for the safety of the patient, but also because of the cost of them. Again, looking across a number of studies, they've reported results somewhere between 20 and 56% reduction in infections and HAIs. The table on the road is showing, the table on the right is showing the infection type if it's listed in the study. Some of them just listed all their HAIs combined. Some called it out specifically for whether it be C. difficile, Caudy, UTI, MRSA, BSI, or CLABSI. And so you can see what the number of studies that had those, as well as what the average HAI relative change was. And so the overall average was around 42%. And then it was also showing the pre and post hand hygiene changes. And so overall, it was about a 25.5% improvement, which you recall back was right in that window of the Hawthorne effect that we were seeing. So you're helping to offset what that Hawthorne effect was. And then if you use the average relative change, if we use the percent reduction of up there, the HAIs combined, the 29.5% reduction, and we use some of the estimated HAI costs, we try to pick some of the more conservative, and obviously if you know your own cost for your institution, that's even better. But you can see it's a fairly substantial. So a example for a HAI count for maybe a 400-bed hospital, maybe they had 7 MRSA BSIs, 7 CLABSIs, 6 Caudys, and 19 C. difficile. Those are the costs that we used in that equation. And then the percent reduction at the 29.5% means that they're, in theory, are reducing about 11.4 HAIs by focused on the improvement of the hand hygiene, which equates to almost $250,000, $242,000 when you add all that up. Next slide. Okay, so when we look at combining those and look at the value that the electronic monitoring hand hygiene and improvement of HAI rates, you can see that now we're approaching almost a $500,000 a year. This is a fairly substantial value. Again, this is a lot of times what, whether it be infection prevention or clinical staff can use to take to their CFO or whoever's potentially could be buying in and purchasing this to say, okay, this could be the impact that we could start to see. And this would be something that could be maintained year over year. Obviously, you're not going to have a continued 29% reduction year over year, but when you always compare back to that original baseline, you'll see the improvement, the maintenance, and hopefully continued drops. So then the other question is, okay, we see all these importance. Why don't we see more of an impact on HAIs when we have these hand hygiene improvements that are emphasized even without the electronic hand hygiene monitoring? So kind of to help explain that a little bit, if we go to the next slide. I like to summarize this because of it kind of is another good example. So if we take those same studies that were shown before about the impact that they had on the HAIs, and over on the right, we have the hand hygiene rates. The pre-intervention is what you saw before, the actual reported So they range from 29% up to 62%, is what they were reporting out. The actual reported after their intervention was somewhere between about 51% to 97%. I like to throw in that middle column there is looking at, okay, if we were to assume at that baseline, we used the 35% and we add that back in to what the Hawthorne effect could be causing, all of a sudden you see that your baseline, instead of it being the 52%, is maybe closer to the 87%, and actually maybe higher than what the post-intervention actually had. So whenever you have these rates that are already looking better than what they actually are, a lot of times it can be much harder to kind of drive the improvement initiatives, either from leadership to support because they already feel that they're performing well, or from staff if they feel that they're already performing their hand hygiene to the best of their abilities at that point in time. Then it's going to be much harder to kind of move that needle from what's being reported as 85% to 95%. But if they realize that they're only performing at 60%, that kind of gets everybody's attention a little bit more. So just kind of shows the challenges of trying to highlight why don't we just see this more often, even in the absence of the electronic hand hygiene monitoring. Next slide. And then just a couple of quick real world examples that we've actually partnered with hospitals in evaluating. So in one hospital, we saw a 46% increase in compliance. Through that, they also actually saw a compliance rate that reduced from, again, this would be like all their HAIs combined, from 146 in year one, and then 2 years later down to 93. So it was a 70, showing a almost a $500,000 savings from those, or over $1 million actually, savings year over year from their baseline. So again, it's a substantial savings, and then obviously you also have the safety of the patient is the primary benefit that you want. And then the next example, in another example, we also had a site that started around 32%. They were able to get their hand hygiene up to about 75%, which maybe what the direct observations we're seeing all along because of the Hawthorne effect. By doing that, they actually saw their HAI counts drop from 76 to 59 to 49. And so then the cost of those HAIs, again, estimated was dropped from about 1.7 down to about 1.1 million. So again, over $500,000 in savings due to the HAI reduction. So again, it's a substantial, and it also can happen in the real world. So with that, I'm going to hand over to Danielle, and she's going to dive a little bit deeper.
Thank you, John, for highlighting the problems that facilities frequently encounter with direct observations when they're trying to understand what their true hand hygiene compliance rates are, and the effects that even slight improvements with hand hygiene can have on their HAIs. Now, what I'd like to do is to dive a little deeper into what electronic hand hygiene compliance is. So as we know, every facility must have some type of hand hygiene auditing system in place where you're going to capture your data, you're going to be able to set your goals, and then you're going to be able to monitor the results. At CenTrak, we help you automate that system. Our electronic system is a tool. It helps you fulfill your accreditation hand hygiene requirements, but even more than that, it is a patient and a staff safety tool, helping you capture all of the hand hygiene activity so you can understand your current workflows and then focus on improvement efforts. So how does our system work? Well, best practice dictates that staff are going to wash in and wash out when interacting with patients, which is what our solution measures. The wash-in, which soap or sanitizer as indicated, the wash-in is going to correlate to moment 1 of the WHO's 5 moments of hand hygiene that John had mentioned earlier, which is before caring for a patient, and what we indicate as entering into that patient space. And the wash out correlates to moments 4 and 5 after caring for a patient and touching their surroundings. So you can see here in this diagram that if you have one RN that only had 4 patients and during their 12-hour shift only rounded on each patient once, then that one RN will have close to 100 opportunities to wash their hands during just one shift. And of course, we all know staff are in and out of patient rooms much more than that. So our system is going to provide you with statistically significant amounts of data in order to understand your workflows and to help you identify areas for improvement. Now, with our customizable rules, which each facility establishes for themselves, when they're applied to that movement of staff entering and exiting patient spaces, the system is then going to calculate your compliance rates. Next slide. So what are the main components for our hand hygiene system? Well, we have our hand hygiene sensors that monitor all of the dispensers, soap and sanitizer, within the patient flow area. Staff are going to wear their CenTrak badges, and that badge passively communicates with the hand hygiene system, and it's going to capture all of those dispenses. And on top of that, the software is going to display the hand hygiene activity in real time. So that makes your dashboard a proactive tool. Leaders are able to see what's going on their unit with their staff in real time, rather than having to wait for historical reports and then to be able to analyze it. So you can go out and proactively interact with staff during their shift. So from a high-level perspective, we create a defined line at the threshold of a patient space, whether that's a room or a bay. Staff wash their hands, their soap or sanitizer, within the time frame allotted after crossing that threshold, and we capture that activity. And then when the rules are applied, the system calculates those adherence rates. And then all of that data, all that information is going to be shown in reports that you're going to be able to pull based on facility, role, group, and whatnot. Now, how does CenTrak actually calculate compliance? I mean, like, what is that equation? So it's actually a very simple calculation of washes over opportunities. I mentioned earlier, opportunities are the entrance and exit from a patient space. And the washes are how many times did staff perform hand hygiene within the time frame allotted of crossing that threshold. This particular slide is displaying a rule that staff need to wash their hands within 30 seconds of crossing a threshold. But let me give you an example. So say I forgot to wash my hands as I enter room 201. I'm 0 over 1, or I'm 0% compliant. But I wash my hands as I'm leaving within the time frame allotted. So now I'm 1 over 2, or 50% compliant. It's pretty simple. There's no algorithms. It's looking at, did you wash your hands as you entered and exited a patient space based on the rules applied to that specific room? Meaning we can get really specific. So say, for example, a patient has C. diff and it's an enteric precaution room. We can look at, did staff use soap when exiting? Otherwise, they're non-compliant, and the system gives you that visibility for any kind of re-education opportunities. So how does the system know where staff are and what are patient locations? Well, CenTrak uses RTLS, so locating devices that are strategically placed to accurately define the patient space. We call this clinical grade locating. shows staff presence. It shows their precise location and captures when staff cross that patient threshold. So as you can see here, we have the red triangles, which are our virtual walls located back to back at the patient doorway. This creates, as its name implies, a wall of infrared light where there isn't one because the patient's door is open. And then the system captures when staff are in the hallway versus crossing into the patient room. The little blue diamonds represent hand hygiene sensors. So typically there are two dispenser sensors or two sensors in each patient room because you're going to have one for soap and one for sanitizer. And then there's also going to be sanitizers in the hallways in between patient rooms, for ease of use, as well as soap and sanitizer dispensers in staff areas. So we cover anywhere patient-related task would either begin or end. So now that we've talked about, electronic systems and how they work and how it calculates, now what I'd like to do is look at all of the activity that's going to roll up into the reports and how you can leverage this information. So this is a screenshot of our newest report engine that's now available in our cloud-based solution, Hand Hygiene RT, HHRT. As you can see, we have multiple filters that helps you narrow down all of the activity that the system is collecting, showing you the information you're looking for, whether it's by role, department, individual, just to name a few. And when deployed at an enterprise level, it's easy to see compliance rate of each hospital, even helping to compare like departments and share, because then that helps them share best practices so that everyone is going to benefit. So on the next slide are some examples of some of our reports. Now notice the first one, by date. You'll notice there are 3 lines in the graph, and I always like to highlight this one. We show you not just your total compliance rate, but also break it down into your entrance and your exit compliance. This is extremely beneficial when first launching an electronic system. I know I've seen gaps in entrance to exit as high as 50 to 70%. Because, it's very intuitive to wash your hands after you finish caring for a patient. But sometimes it's not quite as hardwired to wash your hands as you're entering into a patient space. So these reports give you that visibility. You can run reports showing how each department is doing or unit, so you can see the health of the whole hospital, or break it down into ancillary services and see them all in one reports. We can break it all the way down to individual staff members. Another nice report is that you'll see is the third one over there on the top, is by your precaution rooms. So you can actually see how are your precaution rooms doing, and then be able to drill down even further to see how those individual rooms are doing. So it's important to understand that technology alone is insufficient to drive sustainable improvement, because success is going to require a combination of technology, but also coaching, feedback, and culture change to truly impact behavior and influence outcomes. During the implementation and consulting phase, our primary focus is on engagement, motivation, awareness, and coaching. These are foundational elements to promote sustained hand hygiene improvement. With engagement, we collaborate closely with your teams of infection prevention, quality, and clinical departments to develop effective hand hygiene strategies for staff and help those leadership to understand how using hand hygiene data can even assist with workflow improvements, such as clustering care when rounding on patients, leaving a room with specimens, admitting patients into critical care, and various things like that. Encouragement and motivation are vital to continuous improvement. We encourage leaders to discuss hand hygiene in their daily huddles, also to ensure that staff are consistently wearing their CenTrak badges appropriately, and that they share, this is key, share the hand hygiene data in a non-punitive manner and recognize those high performers. This is going to be a cornerstone to sustaining any kind of hand hygiene improvement. Now, for awareness, we focus on a multidisciplinary collaboration because with that, we set those measurable goals and promote hospital-wide initiatives. And even key is provide effective messaging to staff. Because in the end, what we were wanting to do is improve compliance and better patient outcomes. Now, lastly, when we talk about coaching, based on recent studies and recommendations from organizations like APIC, we encourage a just culture where a key word or phrase is used by staff to help support and remind each other to perform hand hygiene. At my last hospital, we would say, "Have you seen Connie?" Because she was our IP director. It was very non-threatening. It was kind of cute. It got staff into that mindset where they could even say it to physicians, to colleagues, and it was very non-threatening, just in order to help remind each other to do the right thing. Now, this is a real-world example of one of our sites. The hospital struggled trying to capture enough hand hygiene observations, especially outside of a normal work week hour. Plus, they understood staff altered their behavior knowing they were being observed, so they were concerned that their rates were overly inflated. Now, once the CenTrak hand hygiene compliance monitoring system was implemented, they were able to capture enormous amounts of hand hygiene data. You have to think, it's 24/7, 365. So they were able to meet their regulatory requirements. Also, they could see in real time the activity on the units and share hand hygiene reports openly with staff. And then after analyzing the hand hygiene data, they did identify gaps, and then they were able to implement interventions, which helped them improve their overall hand hygiene compliance rates by 75%. Now, as we wrap up, I'd like to share what's great about our technology. It's scalable. I love it. The same staff badge used for hand hygiene compliance can also enable things like staff safety and duress. So where you already have hand hygiene deployed, you can layer on things like duress protection in those same areas. No separate devices are needed. And because our new badge, our BLE badge that Katie showed you earlier, the same staff protection can easily extend across the entire facility using compatible BLE access points from Wi-Fi vendors like Cisco, Aruba, and Juniper, or if you don't have that, with cost-effective BLE networking options from CenTrak. Now, many clients also use our RTLS system to automate their nurse call cancellation when staff enter a room. It's going to automatically document your response times, and it illuminates the dome light right outside the room. The other things are patient engagement and digital whiteboard integrations. They're really growing in popularity. Years ago at my last hospital, we were early adopters of using staff location data to feed those electronic whiteboards. And it would show the staff member's name, credentials, photos, whatnot. And this, I've found, has quickly become one of our most common technology integrations requested over the last few years. Now, beyond badges, the same platform, so the same backbone, can handle temperature and environmental sensors. Something that I've heard from infection preventionists that they're increasingly managing more of that in their facilities. We also focus on preventing never events like infant protection and wander management, using that same location awareness to automatically lock doors or elevators and send alerts. And finally, if that wasn't enough, We also have asset tracking and wayfinding that can also be leveraged as part of that same platform. So while hand hygiene on its own can sometimes be a big investment, especially in environments with limited budgets, using a consolidated technology platform across multiple departments let you spread both the cost and the benefits, which is a big win for any facility. Part of my role as a clinical consultant here at CenTrak is to help facilities build those ROI models and establish, your internal steering committees, help with your standard operating procedures, and all of that to ensure the platform is used effectively and adopted throughout the organization. And so you can see from the next slide that once you have that CenTrak RTLS backbone, you can easily leverage multiple use cases. As a matter of fact, some of you might already be wearing our CenTrak staff badge as a part of your nurse call integration. And we can easily help you expand to include a solution like hand hygiene. All right. And so the next slide just says thank you for your time and that we will go ahead and open this up for questions.
Thank you so much, Danielle, John. That was so informative. So thank you guys for sharing your insights on our system. So we do have quite a few questions in the Q&A already, but we will open the floor now. So please, if you have any additional questions, type them into that Q&A box and we will answer them as they come in. So like I said, we have a few. The first one in here is, do you need a Wi-Fi connection for the system to work?
So currently, our system, the current hand hygiene system that we have in place, will leverage our 900 megahertz, so our CenTrak Star network, as part of the deployment. So when we start talking about leveraging Wi-Fi and BLE, that really is where we're starting to expand into other use cases, such as duress and asset tracking, wayfinding, and things like that.
Thanks, Danielle. Next question here. I know you touched on it a little bit at the end, but can you reiterate how we can justify the ROI to our leadership team?
Absolutely. FTEs are really where it's at. So I know a lot of times it's very difficult, and especially in smaller facilities where you have maybe one or two infection preventionists and they're out there on the units having to do those direct observations, that the time, energy, and effort in order to capture enough data in order to make that significant is very costly. And then on top of that, you also have HAIs, because we have traditionally seen time and time again an inverse relationship, so that as hand hygiene compliance rates increase, you have a drop off of your HAIs, which are very costly.
Yeah, I was just going to echo that and say that I think that as the years go by, we're getting more and more evidence being published too about the improvements that hand hygiene has on those HAIs. So if it didn't work in the past, I think sometimes updating all that kind of business case with more recent data shows that you are going to see a decline in HAIs if you can improve those hand hygiene compliance rates.
Great, thank you. The next question we have here, how does the system capture when staff opt to use soap and water versus hand sanitizer?
Excellent question. So that is part of our back-end configuration. And so we identify, as I mentioned earlier, we do extensive observations of workflows on each unit that we're going to be monitoring hand hygiene for. And then we will configure the system so that it registers that as that badge is communicating with the hand hygiene sensor, if it is a soap as indicated as you're exiting for those enteric precaution patients, or if it's a sanitizer. So it's really part of the back end build.
Great. Another question that we have here, if you have hand sanitizer right outside of the room and also one in the room, how can the system know if hand hygiene was performed? Would they need to remove one of the dispensers?
Excellent question. So the system itself is based off of timers. So it's not that you have to perform hand hygiene at a specific location, but it's that we're covering and monitoring all of the dispensers where you would either begin or end patient tasks. So if you have your hands full and you're not using the sanitizer as you're entering into a patient space, but you offload your hands and then you're using the sanitizer inside, that is just as effective, and it's going to capture the data as if you have your hands full and you're taking, say, a patient food tray down to the dietary cart, and then you're going to sanitize your hands at that end location. So it's about hardwiring the process of washing your hands as you're entering and exiting that patient space, not necessarily about the location of where you're doing that, but just that it's within the time frame allotted and it's a good workflow.
Great. We have a question here about integration, and they want to know if CenTrak interacts with Epic for monitoring or integrates with Epic.
Absolutely. Yes. So, and not just Epic, although most of you all probably do have Epic. So we do have an HL7 interface, which is very beneficial. And as those rules, as I had mentioned before, that they can be very specific, because you can have a general one that, there's a patient there and standard precautions, but maybe you have one that is on COVID precautions, or one that's on airborne. Then with that integration with your EHR is that we are pulling we're not pulling any other relevant patient data. We're only pulling the precaution status from your electronic health record into the CenTrak system in order to automatically update the type of rule associated. And the rationale behind having those different type of rules is because maybe upon exit, you are requiring soap, or maybe with an airborne precaution, it's going to take staff longer to don and doff their PPE and get in and out of a patient space. So that's where we have those customizable rules. And with that HL7 interface, it can automatically update those rules.
Great. If our organization already has RTLS badges, would we be able to utilize those, or is this a specific system?
As long as your system has the CenTrak RTLS system, then it's very nice. It's very scalable. And a lot of times we will see that hospitals will have our nurse call integration, and then it's not a big leap to expand into hand hygiene. Because you're already leveraging the badge, and now that same staff badge can be utilized and communicate with the hand hygiene sensors that would be part of the hand hygiene system. So it's just continuing to build and scale and grow upon the current RTLS background that you have.
Wonderful. The next question in here, can you measure compliance within a multi-bedded room when the staff does not exit between patients?
Yes. So you can. PACU, ERs are good examples of that, because you have curtained bays or dialysis, if you have chairs and things like that. So you'll have, patients that are right there next to each other. That's where, again, we leverage our technology, our locating technology with the virtual walls. So we are clearly defining, and we are creating virtual walls in between each of those patient spaces so that as staff cross those thresholds, then it indicates I'm in bay 1, and then they leave, hopefully soap and sand, wash their hands, and then if they go down to bay 2. So it's able to very clearly follow that, the badge and see where that badge is.
Great, thank you. The next question, my facility has CenTrak duress badges. Can these badges be easily configured to capture hand hygiene as well, or would we need to purchase new badges?
Perfect. No, that's excellent. So it's the same badge, it's the same technology. There may be minor configuration on the back end, making sure that LF, which is how the system functions and communicates between the badge and the hand hygiene sensors, that's enabled. But more than likely that's already enabled in your duress system. And so it's a easy ability to scale over and scale up to include hand hygiene.
I was going to make one comment too. It ends up being the sensors on the dispensers, but I think both this question and one of the prior questions about if they already have the badges, especially if it's for nurse call or for staff duress, we always like to add on that if they already have something like that, it's nice to have the positive benefit that the staff sees from it. So if they have duress and they're able to get help from it, or the nurse call helps with their automation and cancellations, that's a benefit to them. So a lot of times staff can be a little bit resistant if you start right off with hand hygiene. And so if they already are seeing a benefit that the tool's bringing for them, their buy-in could be a little bit better too, with wearing the badge for hand hygiene and everything. So it's always good whenever you have those value add use cases.
And John, that's actually a great segue, because our next question we have here is kind of a statement, but I know both of you have some feedback to this. Is I hear from nursing that they do not want to be tagged or followed around, and they won't take a badge daily. So I think you guys can both speak to some ways to overcome that.
So messaging is key. And so there are certain words that we prioritize. So we locate, we monitor, we capture. We're not tracking. We track assets. But so we're monitoring where staff are. When you have systems like nurse call integration that are there, and there's staff see the benefit of that because they're able to find their colleagues. They've got automatic nurse call cancellation. You've got your dome light illumination and whatnot. Then they see that benefit, and it doesn't seem like I'm being tracked, which again is part of during the consulting process. We really talk about messaging and how we get the buy-in from staff, because in the end, they're the ones that are either performing hand hygiene or not. And so we have to understand that. And so we're very careful with, with what we're relaying to staff and the messaging that they're hearing.
Yeah, and just to add on, a lot of it too comes with the messaging around, it's not going to be used to track them for disciplinary action or those types of components. So, I mean, I know there's been a number of HR groups that have worked with it to kind of have a policy in place that says that not everybody's going to be able to have access to where staff are going. So it just depends on kind of the safety line guides that you put in place. And then obviously, I think if you have staff duress, they obviously need to know where you're going, because you want security to get there in time for you. So again, that's that big benefit that starts to outweigh that negative connotation of being monitored for their location.
Great. Thanks both. And I know we're at time here, but I do want to ask one final question. Do the dispenser sensors work with any hand sanitizer products, or are they proprietary?
So most. We like to say that we're kind of vendor agnostic, because one of the biggest things that facilities face is a good product and getting staff to use the product. So if you have a good sanitizer system, or sanitizer product and staff are using it, or soap product, then yes, for almost virtually every dispenser out there on the market, we have a type of hand hygiene sensor that we could utilize, whether it's external or even one of our newer ones, which is a drip tray. And in essence, what that does is, instead of the manufacturer drip tray, you're using a CenTrak drip tray that has the technology built into it.
Great. Thank you, Danielle. And so that is all the time that we have left for today. John, Danielle, thank you both so much. We still have a ton of questions that we were unable to get to today. So my recommendation would be, I know the Leapfrog group will be sending out the recording and the slide deck tomorrow. They will also include Danielle and John's email addresses. So please reach out, ask these questions. We have our experts here, and they are a wealth of knowledge. So we'd be happy to get back to you and answer any outstanding questions you may have. But again, thank you all so much for joining us this afternoon. We really appreciate it, and have a great rest of your day.